Thank you for joining me today to discuss trends in buprenorphine abuse, misuse, and diversion. And we'll be using results from 3 U.S. national data sources. I'd like to thank my colleague, Angela DeVoe-Geist, for her work on this project. And I want to point out that Dr. DeVoe-Geist and myself are employees of Indivior. So although buprenorphine is a safe and effective treatment for opioid use disorder, there are ongoing concerns about its abuse, misuse, and diversion. In this study, we examined trends in buprenorphine use, misuse, and diversion and compared it to other opioids. We used publicly available data from 3 large US databases and in order to compare these trends. So the first one is the National Survey on Drug Use and Health, or NSDUH, and that provides estimates of misuse of various drugs in the general US population. The NIFLS, the National Forensic Laboratory Information System, uses data on drugs seized by law enforcement that are sent to US forensic laboratories for analysis as an indicator of diversion. And the TEDS, the Treatment Episode Data Set, collects data from individuals admitted to substance use treatment to provide information on primary drug problem as a measure of abuse. Okay, now we'll talk a little bit about the methods in each of these studies. So the NSDUH provides estimates of the prevalence of drug use and misuse in the civilian, non-institutionalized US population age 12 and older. Each year, data from approximately 67,000 people across all 50 states and DC are interviewed, and this provides estimates for the nation and each state as well for the prevalence of drug use. Starting in 2015, NSDUH assessed past year use and misuse of specific opioids, including buprenorphine, oxycodone, hydrocodone, and as well as several others. And misuse, as you can see here, is defined as use in any way not prescribed by a doctor. NSDUH also measures opioid use disorder in the past year, and it's based on the DSM-4 criteria for abuse and or dependence. And we'll be showing those analyses a little bit. And we use the data from the 2015 to 2017 public use data files. And that link to access those data is shown below. So the NIFLS is a DEA program that collects data on products that are involved in drug cases that are sent to forensic laboratories for drug identification. It includes controlled as well as uncontrolled substances that are secured by law enforcement. It covers nearly all laboratories in all 50 states. And data for this study were obtained from the NIFLS annual reports, and that link is shown below. The TEDS compiles data on characteristics of substance use treatment admissions to publicly funded facilities, but it excludes privately funded programs. Among the treatment admissions characteristics assessed are primary, secondary, and tertiary detailed drug problems, which are available only for about half the states. Approximately 2 million treatment admissions are captured every year, and the trends in treatment admissions from 2011 to 2017 were estimated for buprenorphine and other opioids. And for this analysis, we started with data from the annual TEDS reports that also link is shown below. For data analysis, we looked at counts of events and numbers of events by year from each data set. And the results from the NISDA reflect weighted estimates of prevalence for the U.S. population, for the U.S. population. And we also, for NIFLS, provide prescription-adjusted rates using two sources of drug utilization. Dosage units dispensed, for that we use Symphony data, which provides information on about 90% of drugs, prescriptions dispensed in the United States. We also used data from ARCOS, which is described here, and with the link to that data set. We relied on ARCOS as well because drugs like methadone are not captured systematically using retail pharmacies. So all those prescriptions that are dispensed in opioid treatment programs would not be captured in the retail pharmacy. So we also wanted to make sure that we captured those as comprehensively as possible. Moving to the results. If we look at trends in the past year prevalence in the US in NISDA, the prevalence for the 3 years that we examined has remained relatively steady at 0.3% for buprenorphine. Despite declines in the prevalences of oxycodone and hydrocodone, they remain considerably higher than buprenorphine, whereas the prevalence and misuse of other opioids was similar to that of buprenorphine. So misuse of buprenorphine in the general population is concentrated among those with OUD. 1/5 of those with OUD, as shown in the left set of columns, reported past year misuse of buprenorphine versus about 0.1% of those without OUD, shown on the right side of the slide. Also, approximately 2/3 of those who misuse buprenorphine have OUD, if you look across the rows on the bottom row. The number of reports reported in NIFLS for buprenorphine have nearly doubled, while reports for hydrocodone and oxycodone have declined by about 1/2 from 2010 to 2017. And this resulted in a convergence of diversion estimates of buprenorphine with those opioids by the end of 2017. You can see in 2010 that there were nearly 6 times more reports for oxycodone than buprenorphine and 5 times more for hydrocodone. And by 2017, you can see, as I mentioned before, that those numbers are very similar for hydrocodone and oxycodone, about 50% higher for oxycodone. Methadone also has continued to decline as well. In contrast to the unadjusted trends, the trends in NIFLS utilization, adjusted rates for buprenorphine were relatively flat, indicating that diversion, as measured by NIFLS, increased as dosage units dispensed increased, and also grams distributed increased. For other opioids, there were declines in the utilization adjusted rates, suggesting that the decreases in the number of drug reports exceed decreases in utilization. And also, you can see that the dosage unit and gram adjusted rates for buprenorphine exceeded those for other opioids, although although morphine equivalent grams adjusted rates were lower for buprenorphine due to the high morphine equivalency of buprenorphine. So you can see in the TEDS data that if you look at the buprenorphine column, the buprenorphine emissions have increased, although they account for a very small percentage of overall opioid emissions. In 2011, you can see that there were no opioid treatment emissions for buprenorphine as the primary detailed drug problem, but these increased in recent years. And you can see that opioids, there were 328,000 cases of opioid admissions, opioids as a primary drug in 2017. And you can see that buprenorphine accounts for less than 1% of those cases. Heroin has increased considerably over the time interval that we examined, from 111,000 to, it's covered up, move me out of the way, to 255,000 by 2017. Okay, so this slide really summarizes the results, and I don't really need to repeat all that, but that's there for your information. If you'd like to have everything in one place. Oops, I guess I better hurry up and finish. So in conclusion, the misuse of buprenorphine has remained relatively stable in the general population. And you can see that it's really concentrated among those with problematic opioid use. It's important to understand whether abuse and diversion occurs in order to meet the demand for self-treatment of opioid problems, such as to maintain abstinence and prevent withdrawal, or for abuse, that is, to get high. And I think the body of literature that's been accumulating points more towards people using buprenorphine for the former reasons to self-treat, consistent with self-treatment versus abuse. We saw that the diversion of buprenorphine as assessed in NIFLS increased proportionally with its utilization. And we saw that there were increases in those entering OUD treatment who report buprenorphine as a primary drug problem. But we really aren't clear what the reasons are for that. It could be that there was increased detection in the TEDS for those states that provided detailed drug problem information. That over time they may have added, more states may have added questions, including buprenorphine as a response. But it could be possible too that individuals who initiate self-treatment of OUD with buprenorphine prior to entering treatment start using buprenorphine more and other drugs less, so that by the time they enter treatment, buprenorphine is the primary drug that they're reporting using. So in conclusion, really, the key thing here is that misuse and diversion of buprenorphine remain important concerns. We really need to try to understand what these changes in buprenorphine mean. And really what's critical is to balance the demand for effective treatment with the minimizing the risk of diversion. So with that, I'll end and look forward to hearing your questions at the Q&A session if you'd like to join me there. Thank you.